affluent democracy, which of course Canada is, 80%, roughly speaking, of the population would comprise what one of the world's most distinguished economists, my economic hero as a doctor, John Kenneth Galbraith, called in a book which all of you should read, called The Culture of Contentment, The Contented Majority. As you know, this Canadian of Scottish descent, born in Ontario, has provided, to my view, the most lucid account of the climate in which this P3 story gets fertile soil. The tax-averse, contented majority of the affluent part of the world, including Canada, obviously, dictate the electoral priorities of elected governments. The underprivileged minority are relatively powerless. That is, the poor, the unemployed, ethnic minorities, and possibly the elderly. In North America and the United Kingdom, the dogma that the private sector is good and the public sector is, quote, bad, is dominant. Now, one point I want to emphasise is this is much less so of social democratic governments in continental Europe. In Britain, since 1979, the period defined by the Iron Lady as Thatcherism, underinvestment to placate the tax-averse contented majority has produced progressive deterioration in the quality of key public services, notably public transport, schools, and the public health service, referred to in Britain as the NHS. The dogma, I use the ideological dogma that market forces and the private sector are always more efficient than the public sector, has led to the progressive privatisation of public services in the United Kingdom. Transport services, bus services, have been patchy to very poor. In rural Scotland, rural England, it is now very difficult for the poor or the elderly to get a bus to go into town to market. This is a result of the removal of subsidies and the privatisation process. The rail services in Britain can only be described as catastrophic. I use that word deliberately, due to the deliberate fragmentation, privatisation, dual separation of track and trains, to the point that this is now threatening the electoral success of the next current Labour government. There have been a series of spectacular crashes, and the British public are now worried about travelling on trains. We have the worst privatised train services in Europe, if not North America. Going to the NHS, the non-clinical services, that is to say cleaning, catering, portering, have been privatised, cheap and rather nasty privatisation to the lowest bidder. And as a result, all of this is evidence for this is widely available, poor to reduced standards of hospital cleanliness and food are now the norm in British hospitals, with adverse consequences for cross-infection, with multiple resistant staphylococci and so on. There have been a number of large-scale, what I could only call privatisation disasters: passport agency, computer projects, social security, local authorities, which I'm not going to go into, but they are all evidence and all there. To the extent, and this may not be known to you, that the deterioration of the quality of public services, health, transport and education, is now the dominant political and electoral issue in Britain for the contented majority. That's most people in this room, I would guess, and it may determine the outcome of the next general election. Finally, the bed shortages have created chaotic problems, to some extent shared with all hospitals in Britain because of previous cuts, but they are worse in the Downsized Hospital, with acute emergency admissions having trouble getting in, doctors phoning in, not getting beds, cancelled elective admissions, people phoning on the morning of admission to find they can't get in, particularly in winter, and very high levels of stress among patients, and I have to say, regrettably, a fundamentally demoralised medical and nursing staff. Let me now move away from the specific instance of Edinburgh to other problems that are essential to this wheeze, the P3 wheeze, the British import that is being sold to you by your government, and I guess by the conference starting tomorrow morning. First, as I've said, downsizing is not equated by improved efficiency. The health service in Britain has been run at full blast. It has run out of road currently in regard to efficiency for both acute inpatients, day cases and transfers to the post-acute sector, the private nursing sector, which is itself in crisis. In these hospitals there are delays in resolving structural defects in the hospital, of which there have been many. Restricted rights of access by hospital staff, for example, to equipment because of concern about infection control, because they do not own the plant. Difficulties over private cleaning services, meeting agreed standards, again negotiating with the dual control mechanism. Who does what arguments about the duties of maintenance and portering staff to routine electrical faults. Variable managerial quality in the private consortium and the NHS sector. Poorly paid staff, stressed with low morale. The turnover of executives in the NHS health service in Britain is very high, with a median time for managers of 2 to 3 years. Recurring bed shortages. This is not Edinburgh, this is the other 2 hospitals in Scotland, largest hospitals. Recurring bed shortages with cancelled elective admissions and severe difficulties in accommodating emergency admissions. And the last problem with the P3 project is a more fundamental one. That is to say, a 30-year contract for a hospital imposes rigidity and inflexible standards on an evolving and rapidly changing hospital design in response to changing technology, as medical advances demand changing structures. Altering inflexible 30-year contracts is expensive. These contracts are tied up in legal expertise, the legal expenses are colossal and the lawyers win. And since I gather that British Columbia is a rather conservative state, and perhaps the Conservatives are not here, let me read you a comment, all of this is available, from John Appleby, who is Director of the King's Fund in London. That's the largest independent think tank in the annual review of the King's Fund on the Labour government's performance on health care. This is P3, I'm just quoting. P3 locks in traditional patterns of acute care, but they are changing fast. Labour has entered a massive building programme without an assessment of future requirements and without transferring any substantial risk from the public to the private sector. P3 hospitals could quickly come to have the wrong layout of wards and the wrong balance between long-stay day case and outpatient treatment. Continuing change in medical and information technology suggests that hospitals as we know them today may not be needed in 10 or 20 years, yet P3 is locking the government in for 30 years or more. My conclusion, ladies and gentlemen, based on direct experience, of which I have only given you a small segment to try and explain the background for this import which you are being sold from the United Kingdom, is as follows. P3 projects in healthcare provide poor value for money and should be rejected in favour of more conventional methods of funding major public sector projects. Canadian provincial and federal governments may still have time to learn from detailed scrutiny of objective evidence from P3 new UK hospitals relying on evidence and not visions. Thank you very much.